something like that. It could be iatrogenic. It's less likely in cattle than with horses because we're not usually doing joint injections in cattle, more likely due to them stepping on something or getting caught in wire or something like that. When it's a direct inoculation, it's usually just one area. So you always want to check for wounds, and any age can be affected. You can also get infective spread from soft tissue. If the soft tissue has an infection, it can penetrate into the joint. That's also a common source for digital septic arthritis. So if there's infections in the interdigital space, or sole ulcers, so the infection starts in the foot and then migrates up into the coffin joint or distal interphalangeal joint. And it could also be due to traumatic injuries. This is more common in adults, but technically any age can be affected. And then hematogenous, this is most common in neonates, and the umbilicus is the most common site of the original infection. So their umbilical artery or vein gets infected, and the bacteria gets into the bloodstream and then travels around and infects one joint or multiple joints. The most common bacterial isolate is E. coli, but Salmonella and Streptococcus can also play a role. This usually occurs in the larger joints, and usually multiple joints are affected. And it doesn't usually occur in the pastern or coffin joints because those have a smaller blood supply than the stifle or tarsus or carpus. Clinical signs are usually non-weight bearing because it's a joint infection. There could be an acute onset of intra-articular swelling and pain. And if it's a calf, you want to check the umbilicus to see if it's swollen, leaking, any signs of umbilical infection. Diagnostics are going to be radiographs to see what's going on in the joint, and then an arthrocentesis to get a synovial fluid sample. When they have septic arthritis, the white blood cell count is usually greater than 40,000. They usually have degenerative neutrophils. You can submit for culture. And unfortunately for joint fluid samples, same thing as in horses, we rarely see bacteria present, but it's always good to culture just in case it grows something, because then you can do an antimicrobial sensitivity and see what it might be sensitive to guide your treatment. For large joints, you want to remove the source of the bacteria. So if it's just within the joint, you're going to do a joint lavage with sterile fluids. Usually 1 liter or 2 is what you can get through in a calf. If it's an adult, you may need to put it under general anesthesia and do it via arthroscopy to get a high volume of fluids through. If it's from any type of foreign body or infected tissue, you want to remove that. So for a calf, you're going to have to take them to surgery and remove the infected umbilicus since that's a site of infection. Or within the joint, doing an arthrotomy to clean out the purulent debris and just clean the joint surface. They're usually on systemic antimicrobials for 4 or more weeks because these are pretty severe infections. Cattle like to produce a lot of fibrin, so it can take a while to get the infection under control. And then if it is a neonate, giving them colostrum or plasma to try to fight the infection, especially if they have failure of passive transfer and don't have appropriate antibodies. You also want to try to limit further inflammation, so putting them on NSAIDs. In the United States, we have FARAD, which regulates what medications that we can give food animal species. So phenylbutazone or bute is something we use a lot in horses, but it actually cannot be used in food animal or production animal species. So we can only use Banamine or meloxicam. Those are the only legal drugs that we can use because the other ones have residues that can affect people or that can be in the meat that we eat. So I don't know if you have a governing body that runs that to make sure you don't, that regulates what medications you can give animals that are intended for food. So again, for us, we can only use Banamine or meloxicam. Those are the only approved medications for food animal species. Lavaging the joint can also help limit inflammation because it gets inflammatory mediators out of the joint, and then the antibiotics, again, will help with the infection. You want to try to limit pain, so controlled exercise or keeping them on stall rest. This can be hard depending on the farmer's setup, but ideally they can put the cow or bull in a stall that's nicely padded and soft on good footing. Treatments kind of depend on the severity of the infection. So an acute infection, there's really no bony changes. So you're going to do the same as you would for large joints. So this is within the digit. So antimicrobials, if you can lavage it, great. Pain medication, things like that. If it's a chronic infection, so more than 7 to 10 days, usually at that point, the digit is too far gone for basic medical management. So you'll need to amputate the claw. This is the best option for lighter weight animals. So heifers and steers that are a year or two old versus really big breeding bulls. This isn't going to be a good option for them. Another treatment is called facilitated ankylosis, where we go in surgically and remove the joint cartilage to try to stimulate the bones to just fuse together. So that gets out the infected bone and can make them more comfortable once the joint is fused. Or doing an arthrodesis. And for an arthrodesis, we actually put like plates and screws in to force the joints together. This would be for very heavy animals and high value. This would be an expensive surgery because it's internal fixation. This is an image of doing facilitated ankylosis in the digit. This is showing a solar approach where we're going through the sole to the distal interphalangeal joint, and this drill bit is going through the joint, removing as much of the cartilage as possible. And in this image, it's a lateral approach with the curette. There's a lateral and a dorsal approach, and the curette is used to get rid of as much cartilage as possible. And then after this, we would place them in casts, essentially to prevent the joint from moving, to allow the bones to fuse together. And once they fuse together, that will eliminate some of the pain. Will hopefully eliminate all of the pain over time. They need to come back about 4 to 6 weeks later to have their casts changed and radiographs taken to see if there's fusion. If not, they may need to have another cast placed. Sometimes the infection continues and we have to repeat the procedure. It just kind of depends on how things go. Prognosis, so if it's treated really early, so less than 48 hours, it's fair to good with antimicrobial treatment and joint lavage, especially if the joint capsule is still intact. If the joint capsule is damaged and has infection within it, the prognosis goes down. In that 2 to 3 day period, if that's when the treatment starts, it's fair with antimicrobial treatment and joint lavage. And it's better if, again, the joint is intact and there's not a lot of infection within the joint capsule and there's minimal radiographic changes. If the joint capsule is damaged or there's severe radiographic changes, prognosis goes down. And even if you don't see cartilage damage on the radiographs, you should always assume it's there at this point because the joint's been infected for a few days, and that gives the bacteria plenty of time to degrade some of the cartilage. Chronic, which is more than 7 to 10 days before treatment's initiated, there's almost always articular and bony radiographic changes. And in the large joints, that's a grave prognosis. The large joints need all of their cartilage to function appropriately, versus the lower motion joints where we can do the facilitated ankylosis and things like that, because those joints don't have to move as much. Fair to guarded in the distal digits with surgery. So there's a better prognosis for the coffin joint versus the pastern joint. There's a poorer prognosis if the proximal aspect of P2 is involved, if the second phalanx is involved. And then if the flexor tendon sheath gets infected, that also decreases the prognosis because the infection is in the joint and a tendon sheath. So that's 2 areas that are infected, and that definitely has a lower prognosis. Another condition we can see is cranial cruciate ligament rupture. It's usually seen in heavy peripartum joint cows. Clinical signs are going to be mild to moderate lameness. There may or may not be joint effusion, and they usually have some internal rotation of the limb. Diagnostics are kind of similar to what you would see in a dog, so doing a cranial drawer. These 2 images are showing different techniques to try to get that cranial drawer. So in this image, she's standing behind the cow and using her knees against the hock and then pulling backwards to see if she can get movement. He is just using his body weight and trying to thrust backwards to see if there's movement in the stifle joint. And then this is checking for the rotation within the limb. There's a couple of different treatments, capsular imbrication, cruciate reconstruction, or just supporting it with a splint and rest and see what happens. The prognosis, especially in adults, is guarded to poor because they're so heavy. And even with the capsular imbrication or cruciate reconstruction, they're big animals. Everything we have that we can use for those things are what's used in people. And even large dogs with cruciate ruptures can have a poorer outcome than some of the smaller ones. So it kind of just depends on the animal, but in general, not the best prognosis overall, just due to their size. Coxofemoral joint luxation can occur. It's usually in younger cattle, ages 2 to 5. The cause is severe trauma, and sometimes it can be secondary to obturator nerve paralysis, which can occur in some cows after giving birth, or if they slip on the surface and splay their hind legs out. Clinical signs are going to be very lame. The limb will be shortened on the affected side. There'll be asymmetry of the greater femoral trochanters and usually crepitus on the affected leg. So you want to evaluate the position of the greater trochanter, the tuber ischii, and the tuber cocci. They should make a triangle, like you can see with the tape. But when they have a luxation, you can see that there is uneven height between the coxofemoral joints and the pelvis in general. So this image shows just that unevenness. So again, the luxation disrupts that triangle that we should see. I'm sorry, one of my dogs just started barking. The most common direction for the luxation is cranial and dorsal. In treatment, if you can get it reduced within 24 hours, that's ideal. After 24 hours, especially when the larger cattle, they're pretty much non-reducible. The muscles have contracted and you can't fight with those muscles to try to get it reduced. Prognosis is fair if you can get it reduced. If you can't get it reduced, it's guarded to poor. So now I'm going to give you a few cases just based on some of the stuff that we talked about before we move on to some of the fracture things. So case 1 is a 7-month-old steer. He had a hind limb lameness for about a month. There was no change or improvement with the lameness with Banamine, dexamethasone, or meloxicam. So they tried 2 different NSAIDs and a steroid. The current owners picked him up a week ago, even with this lameness. And there's no known history of trauma, so no one really knows why he became lame. So he came in and we took some radiographs of the stifle because he had swelling in that area. And so that was the lateral. This is lateral. The other one was cranial caudal views. And if you look closely, you can see here's the tibia and the femur. And the femur should be a little bit more cranial than where it is in this lateral radiograph. And then this was a special view we took called a stressed lateral. So in the next image, we have both cranial caudal radiographs together. So this is with the limb in a neutral position. And so you can see the joint space on the medial and lateral sides of the stifle. And with this stressed lateral, what we did is we took the limb and pulled it laterally. And in normal stifle, this shouldn't really affect the radiograph at all because they have all the soft tissue structures to keep everything appropriately aligned. But if you look in this radiograph, there's the joint space on the medial side of the limb is now larger than what it is over here, indicating some disruption of the soft tissue structures in the limb. So this steer was diagnosed with a cranial cruciate rupture. Recommendation was a capsular imbrication or cruciate repair. Since it was a 7-month-old steer, it was smaller, had a better prognosis than if this happened in an adult because he was probably 400 or 500 pounds. So on the smaller side compared to a full-size steer that's closer to 1,000 pounds or 500 kilograms. The other options would be rest, or if they didn't want to do anything, would be send it to slaughter. I'm pretty sure these owners opted to just rest it and see what happened. They wanted to try to get it to some sort of better weight before sending it off to slaughter, but they did not go for any type of surgical repair for that steer. Second case is a 5-year-old cow. She is lame in her left hind limb for about a month. There is no improvement with rest, and she's also about 7 months pregnant. So this was her, and she came in, and if you can see, she has some swelling on the left coxofemoral area. And we put some tape on her so you could see right to left of where her coxofemoral joint, where that triangle should be. There's the right side, and there's the left over on that swelling. And so there's a couple different pictures from some different angles. So from above, you can see a lot more swelling than we can see just from behind. And I don't have a video of her lameness. I had it somewhere and I couldn't find it, unfortunately. So she was diagnosed with coxothermal joint luxation, and a recommendation for her, because it had been going on for a month, she was large. There was no way for us to even attempt to try to reduce that luxation, was to send her to slaughter. Here, where they don't tend to euthanize cattle if they have a poor prognosis, they just try to get them to market to see what they can get for them, unless it's something very catastrophic to where they wouldn't even make it to market. So that's what they ended up doing with her. Actually, I think they took her home first to see if they could wait out the pregnancy. And after she gave birth, they were going to send her to slaughter. So that was what happened with her. Okay, are there any questions so far?
มีคำถามไหมครับถ้ามีคำถามให้เขียนลงในแชทได้เลยนะทุกคนเปิดวิดีโอให้เห็นหน้าหน่อยดิ Okay, you can continue, Dr. Joanne. Thank you.
All right, perfect. Okay, so the next thing we'll talk about is fractures of ruminants and camelids. And I believe I have you all for the next couple lectures on the weekends. So we'll do equine fracture, I believe, is our next one. And in that lecture, I'll talk more about fracture classification and stabilizing fractures for transport. For this lecture, I'm going to go more of what we can do to stabilize fractures specific to ruminants and camelids and some of the conditions they have. So the prevalence of fractures in at least the US hospitals is around 2.5% of hospital admissions for fractures in cattle. Most of them are in calves, and it's usually for dystocia and almost always improper use of chains. So the calf gets stuck, the owners put chains on the calves and try to pull them out. They pull too hard. I've had some clients attach the chains to tractors to try to pull them out. That's not safe for the cow, and it's definitely not safe for the calf. It's a lot of force, and that can cause the limbs to break. And the other common cause is they just get stepped on by the cow. This is the location of where a lot of those fractures can occur. I'm not going to read the list to you, but in several different areas of their body. The advantages of ruminants and camelids as patients in general is they have a much calmer demeanor than, say, our equine patients. They also don't have to return to an athletic career. Some horses need to go back to racing, jumping, things like that. Cattle just need to go back and be able to eat and grow pretty much. They also lay down a lot during the postoperative period, so they give their limbs a break. Horses tend to stand a lot more, and so that puts a lot of pressure on the fracture, and then anything we use to repair the fracture. So just the overall demeanor of ruminants and camelids helps them with fracture repair. They also have a large potential for bone healing. They have a much higher vascular density of their bone compared to horses. And they also have an enhanced cambial layer of the periosteum, which is the osteogenic layer. So they have a lot more osteoblastic progenitor cells to come in and try to help repair the fractures compared to horses. Horses don't have nearly as good of a vascular supply and propensity to heal as our ruminant patients do. They also rarely have contralateral limb complications. Sometimes for horses, it's not the fractured limb that fails, it's that they get laminitis or limb breakdown in the other leg that's supporting their weight, again, because they tend to stand versus lay down. So we don't see laminitis or limb breakdown in the other limbs and ruminants nearly as much as we would see in horses. They're also much more amenable to bandages and splints and external fixation devices than horses. So we have a lot more non-internal fixation, so external coaptation options to try to help these patients with their fractures than what we do in horses. As I said earlier, some general considerations. I don't know what governing body you have, but for us, it's FARAD and MDUCA that regulate what medications can be given, and they have to be followed. Cattle in this country are considered primary food animal species, so cattle, pigs, turkeys, and chickens, which means we have to follow the laws to a T. There is no wiggle room for anything. Sheep, goats, and alpacas and llamas are what we consider secondary food animal species. So we are allowed to give some drugs off label to them, some medications, but we cannot for cattle. So whatever governing body you have in your country for that, you always want to make sure you follow that. Even if someone says, oh, it's a pet and it's not going to go into the food chain, at least for here, you still legally have to treat them as if they could end up in the food chain. Otherwise, you could lose your license to practice veterinary medicine. So to start off, we have economic considerations. So a lot of times our cattle and production animals, they're a livelihood for our clients versus horses, dogs, cats might be more pets. These are usually business. So decision to treat could be based on the severity of the injury, which includes soft tissue damage, if the fracture is open or closed, and the location and type of fracture. So a humeral fracture versus a metacarpal fracture and things like that. Cost of treatment. So again, the type of fixation needed. Again, cattle and ruminants are a lot more amenable to some external coaptation treatments that we can use that we may not be able to in horses. This patient here was I think he was a 600 kilogram bull. He came in for a different condition and he ended up getting radial nerve paralysis, and we were able to manage him. This is a bandage and a splint for that condition to help support him through it. He did really well and eventually made it through and was able to walk on the trailer home. Another consideration, again, is just the expected success rate. Are they going to be able to go do the production that they need, whether it's grow for meat or breed cows if they're a bull, or produce milk like they're supposed to? And then the perceived potential and economic value, depending on the production. A lot of times bulls are considered more high value than cows in many cases. If you're looking at dairy goats, the does are considered more high value than the wethers. So they might put more money into the females over the males because the females are the ones producing milk, not the males. And then the temperament of the patient. Even though the ruminants tend to be calmer than horses, I have dealt with some very angry cows and some very angry bulls that just constantly try to charge at you and things like that. And there's 600-700 kilogram animals, they could kill you. And if they aren't amenable to being treated, you may not be able to help them no matter how much you want to. This is just a chart kind of going over what I just talked about as far as how to decide who to treat, how to treat, and what the prognosis might be. So questions to determine treatment is one, is treatment required? Is it something that some stall confinement and rest can help? If it is fractured, can the fracture be reduced closed, or do we need to actually make an incision and do an open reduction? Can the fracture be adequately immobilized with external coaptation alone? So will a cast just work, or does it actually need plates and screws or some type of internal fixation? And then again, the cost benefit of those treatments. So this is a calf that came in. I think he was stepped on. And you can see this is a simple fracture. I'm in the fused third and fourth, I believe this is metacarpal bone of this calf. It's a simple fracture. There's very minimal displacement. This can easily be treated with a cast and rest. Not a big deal, very easy to fix. Versus this calf, this was a calving injury it was presented hind limbs first and they pulled it out. And so the proximal tibia is fractured. And so obviously that's going to be much harder to fix. And then this calf over here is a different one, and it had a femur fracture. And if you look closely, this is the medullary cavity of the femur. This is the first time I've ever had the inside of a femur look at me on a radiograph because of how severe the fracture was. So both of these are higher up in the limb, much more complicated. This one's a comminuted fracture. Neither one of these are going to be able to be treated with a cast alone. Internal fixation is going to be difficult anyway because of the location, but these are going to be much more expensive to treat. And even with all the money in the world, and if they are willing to do any treatment possible, still have a guarded prognosis just because of the severity of the fracture and where it is on the limb. And then this calf, the fracture's open, even though it's in the third and fourth metatarsal bones. It's a oblique fracture. There's some comminution, but you can see all the gas opacities in this area. So open fractures have a poorer prognosis than closed fractures because they're much higher risk of infection. The wound was over here, and I was able to stick forceps through to the other side of the fracture line. This calf, I can't remember, I believe it was stepped on, and then they left it for about 2 days before they brought it in, so it didn't have any support to the limb. Had they brought it in right away, it may not have become an open fracture, but this one did not have a good prognosis. The owner wanted us to try to fix it, but there really wasn't much we could do because they didn't want to pay for us to do plates and screws and do internal fixation. So this one ended up being euthanized because it had a very poor prognosis with the open fracture and the infection. He also had a fever when he came in, so was also systemically ill. So a lot of factors against him. This is just a diagram talking about how to support fractures in various areas of the limb. We'll discuss this more next week in the equine lecture as far as splinting for transportation, just basic stabilization initially for fractures to get them to a hospital for treatment. Casts, so these are most useful for closed fused third and fourth metacarpal or metatarsal bones, so the cannon bones, especially if they're simple transverse or oblique fractures or Salter-Harris type 1 or 2. And we'll talk more about fracture classification next week as well. And casts are also good for injuries that don't require wound care. If there's a lot of wound care, casts aren't going to work because you need to be able to treat the wound, and you can't do that if there's a cast covering it. You want to make sure you immobilize the joint above and below the fracture. And this is a little bit easier to do in the front limb than the hind limb because the front limb is straight. The hind limb bends at the hock or tarsus, so it can make casting a little bit more difficult. Any fractures proximal to the distal radius or the distal tibial physis, casts are not appropriate because they're not going to get enough stabilization because the cast can't reach up to the humerus or femur to get the joint above and below those fracture lines. Because again, you want to mobilize the joints above and below, and that's just not possible higher up in the limb. So the technique for this, you want to put them in lateral recumbency with the affected leg up, and they're either going to be under very heavy sedation or general anesthesia, depending on the temperament of the animal. For most of these, it's easier to drill a small hole in their claws, especially in full-size cattle, and put wires through the claws, and that will help facilitate traction to reduce the fracture. And you assess the reduction of the fracture by palpation or with radiograph. So this is that wire technique. This is a full-size cow, and so there's little holes drilled into the toes of the claws and wire attached to a rope. And you can see this, which is a bull on a tilt table, and someone is pulling on this rope to get the leg one straight in an appropriate anatomical alignment and just applying traction to get the fracture back in the appropriate anatomical position. The books always say, oh, just reduce the fracture and make it sound very easy, but it's not. The muscles, as soon as the fracture occurs, all of these muscles and tendons start to contract. And so you're fighting against that contraction that's taken place. So that's why it can be very helpful to do this drilling technique and have someone assist and pull on the rope. Sometimes we'll put them in dorsal recumbency and attach the rope to the hoist, and then use that, so something in the ceiling, to lift up and really counteract the weight of the animal to try and reduce the fracture. The next step for the cast is putting felt over the bony prominences between the claws and under the dew claws. So these are the dew claws, so there's felt that's slightly taped underneath, and then I always put felt in between their claws as well because you're trying to prevent pressure necrosis while the cast is on. Then you do a double layer of stockinette. So this is the stockinette up and down the limb. For this calf, the other thing you see here, this is a fluid line, and inside the fluid line is giggly wire, and that's put on either side of the leg. And so you can actually use that to remove a cast later instead of having to use a cast saw. And it's nicer in the calves or in lambs or kids because you can cut them with a cast saw because the cast is a lot thinner than what it would be on a full-size animal. So this is another technique to use to cut a cast so you don't have to use a cast saw. And though also, once you have this on, you'll put a felt ring at the top of the cast. So on this animal, it's going to be right here, right below the olecranon. And that's going to be the top of the cast and where you'll start with the casting tape. So once you have this on, the fiberglass casting tape is applied again, starting at that felt ring. And you want to select the width that will allow, that will conform well to the limb without any extra folding. So in lambs and small calves, it's usually about 2 inches, or they're probably about 4 centimeters in width. Adult animals might be 6 centimeters wide. And then you spiral it around the leg and you want to overlap by 50% every time you go around. So this is what the cast should look like at the end. Key points in placing a cast for fractures, you always want to include the foot. You don't want them to be able to move that because that can, if they can flex their foot, that will change the tendons and ligaments, and they can rub up against the cast, which can lead to cast sores. So you want to make sure the foot is immobilized. And the limb should be casted in a normal neutral position as if they were standing. That way, when they're up and walking around, they're able to bear weight as normally as possible. And again, that helps reduce the risks of cast sores. In patients that have a lot of soft tissue swelling, the initial cast may need to be changed in 4 to 7 days instead of in younger animals. So calves, lambs, and kids, you usually are changing them every 10 to 14 days because they're growing. And adults, you can change them every 3 to 4 weeks. But in that initial period, if the swelling's very severe, that initial cast actually acts as a compression and can reduce some of that swelling, and then the cast will loosen. So you may have to put another one on a few days later once that soft tissue swelling has decreased. This is a calf that came in. I believe he was stepped on. And you can see it's not a simple fracture, but it's not very displaced. There's not a lot of comminution. We're able to get it. So this is before reduction. This is after reduction. So you can see how it's tilted a little laterally here, and it's a bit more straight here. And so we're able to put a cast on. And then since this was a bit of a calf, it came back 4 weeks later. You can see new bone formation. It looks pretty good on the DP view. On the lateral view, it's not perfectly aligned, but it's still pretty good for what we could expect with this calf. And so for him, we took the cast off and put another one on for another 3 to 4 weeks. They didn't bring him back after that. I'm assuming their vet on the farm took the cast off and that the calf was doing well. But this is one that just shows cast application can be sufficient for fixing these fractures. Aftercare and complications. So again, you want to assess the alignment after the repair. Depending on the type of fracture, sometimes the bone fragments might collapse or override as the animal walks on the cast. I do have an example of that later on in the lecture. But minor displacement, like we saw in the previous radiograph, is not that big of an issue. Again, cattle like to heal, so their bones like to heal, and they're very good at it. Once the cast comes off, again, there's 8 weeks of stall rest, daily evaluation for cast sores, any changes in lameness, things like that. The casts get changed in older animals every 3 to 4 weeks to accommodate their growth. Cast breakage is the most common catastrophic complication. It tends to happen on the concave side of the cast because that's where there's more compressive forces. If that happens, the cast has to be removed immediately, address any injuries that could have occurred, and then reapply a cast if that's the appropriate treatment option. They can also get cast sores. And again, contralateral limb issues are much less common in these species than in horses, though they can get dropped fetlock secondary to overloading. So in this image, you can see in this leg, the fetlock has dropped significantly because this leg was bearing more weight while this leg was healing. If that happens, once the fractured leg is healed, the dropped fetlock should resolve over time as they're able to bear weight evenly on both limbs. And here's some examples of cast sores. This is a horse, but it's a good example. The purple stuff is something the owners sprayed onto the cast because they thought it would help with the bleeding. Every time this horse stepped down, blood would pour out of the back of the cast. That's not ideal. That they should have brought this horse in much sooner than they did. And you can also see on the front of the cast, there's a wound on the top of the cannon bone. When we took the cast off, these were the lesions it had on its fetlock and what were bleeding. Luckily for this horse, the injuries did not go into the joint, but that is something that can happen with casts. This is a calf that had cast complications, and so you can see blood on the inside of the cast. This calf's name is Fierce, and we will revisit her case shortly, and I'll let you know what happened with her with all the blood. After they're in a cast for a while, we have to wean them out of a cast, which usually involves putting them in a splint for a while, and then splint to bandage to just being able to walk around normally, because you don't want to go from full support of a cast to nothing, because that can increase the risk of injuries of their tendons and ligaments in the limb that was casted. So this is a little lamb. It was a week old, and I think it got stepped on, and it had just a very simple fracture. So it was in a cast, and then for 2 or 3 weeks and came back and was much more stable. And so when we weaned it to a splint, we actually just used the backside of the cast as the splint because it was already perfectly conformed to its leg. And so because it was so little, we didn't use full bandage material like you would on an adult or a full-size calf. So we used cast padding and then put vet wrap around it. And then there's elasticon at the top and bottom to keep the bandage in place. And then we put, again, the backside of the cast we used as a splint and then just taped it around its leg. And so it stayed in this splint bandage for another week, and then just the bandage for a week, and then was weaned out of it. And this little lamb did great. There's also splint cast combinations that can be used depending on the type of fracture. A common one is called a Thomas Schroeder splint. It's suitable for fractures higher up that a cast alone isn't going to be able to manage. So all closed radial fractures, except at the most distal aspect of the radius. And this can be successful for, or at least in the literature has been successful in cattle up to 400 or 545 kilograms. So it won't work for really, really big cattle, but it can work for some pretty large ones. It can also be used for most tibial fractures, and that's been successful in cattle up to 1,000 kilograms, cruciate ligament ruptures, and it also can be used for animals that are too heavy for internal fixation. So one of the things you have to remember is all of the instruments we have for internal fixation, the plates, the screws, the pins, they are all developed for people. So even the most obese person might be around 400 kilograms, which is a small cow, a small horse. So we're using those instruments for our patients who also have to get up and walk right away. So we do have some animals that they're just too big and everything will fall apart if we even try to do that. And since cattle are a lot calmer than horses in general, we are able to do these splint combinations to try to help them through this that we wouldn't necessarily be able to do in horses. And then other fractures, so heavily comminuted fractures that might be difficult to reconstruct. The Thomas Schroeder splint can also be used for that. And it's also cheaper than internal fixation and other things. But a key here is they have to be able to walk on their other 3 legs for this to work. If they can't move on, if it's one hind leg has a fracture, but they can't stand on the other hind leg, this treatment will not work. So to make the Thomas Schroeder splint, you actually make it out of metal, and you, depending on how big it is, if it's a small calf and it's small metal rods, you can bend them around buckets. But for full-size cows and bulls, you're going to have pretty thick rods, and you're going to need like a welder or something to help you construct them. If you're going to be seeing cattle on the farm, you might just have some pre-made that you take with you just in case it's needed. But they are shaped into a ring that will fit either on the axillary or inguinal regions, and they have to be large enough that they don't contact the bony protuberances, so the tuberococci, things like that. You don't want those to get rubbed. And then the vertical rods are continuous from the ring to the ground, as you see here. So this is the ring that will go either over the shoulder or over the pelvis. And then these vertical rods, this one is bent because it's for a hind leg, not a front leg. So it has to be bent at the tarsus. And then there's a U shape on the bottom, and then that's where the foot's going to go. And it's going to go a little bit below the foot. Depending on the size, the vertical rods, since you'll have these coming down from the ring and then others coming up from the U, they're taped or welded together depending on the size of the Thomas Schroeder splint. So to apply this, the patient's in lateral recumbency with the affected limb up, you're going to reduce the fracture, and you may have to do it the same way that I described earlier for placing a cast. And then you place the splint around the limb and you pat it as needed because you don't want to cause sores. And then the limb is covered in a double layer of stockinette. And again, as we talked about, drilling holes into the hoof to help reduce the fracture. And you secure and after you do that, you secure the hoof to that bottom bar of the splint because you want to keep keep the fracture reduced and keep the foot in a semi-normal anatomic position. And that's also to keep traction on the fracture. That's why you wired the foot to the bottom of the splint. And so this is a calf. They already have the stockinette on. You can see the wires on the claws that are wrapping around that U bar, again, to continue to put traction on the fracture. And then if you're doing the Thomas Schroeder cast combination, you're going to put cast material around the limb and the splint. So this is the fiberglass casting material. There's already some on the limb of the calf, and now this is going around. It's attached to the splint and coming around. And then in this image, it's going around the leg and then around the splint because you're basically trying to, one, the cast is supporting the fracture, and then by putting cast material around the limb and the splint, you're making it stronger and keeping the limb as stable as possible. And then since the bottom of the splint is metal, you've got to cover it with something so they have traction and don't slip. So this is the full Thomas Schroeder cast splint combination. And then they still need to pad this metal rod. You don't want to leave just the metal there because it can cause sores on the limb. This chart just shows you the size rod you would need. This is in inches and not centimeters, but what you need for certain size animals. And again, the bigger they are, the thicker the rod needs to be, where you might need a welder to form this type of splint. For patient management, you want to monitor the splint and the cast and the bandage, make sure they're not getting cast sores, nothing slipping, there's no heat anywhere, make sure they're comfortable and able to move. And then monitor for sores. The most common areas are listed here for you. This is a calf we treated. She had a cranial cruciate rupture, and so we were able to treat her with the Thomas Schroeder splint. Since it was a ligament injury and not a fracture, she has a bandage that's then taped to the splint versus a cast. And you can see the padding on the ring, and we have the elasticon going around just to help support the splint and try to keep it from rubbing her. And she was sent home with this and rest. And as far as I know, she did pretty well after a period of time. Another type of splint is called a walker splint. This one is specifically for hind limbs and for tibial fractures. It offers medial support on the limb. It can also be used for cruciate tears. And there's a foot plate on threaded rods that allow for mechanical traction of the limb, so to try to help keep the fracture reduced. These are difficult to build, and you have to have a welder to do this. You can't just make this on the fly at the farm because it's very thick piping. As you can see, this is a big bowl that this is on, so it's not something that's easy to make on your own. This is called a splica bandage or splint, and it's to splint or cast up to the elbow. And so you can see how it's going over the back of this calf to help support it. And it padding is wrapped in a figure of 8 to help support the limb. And then cast material is applied laterally from the ground to the dorsal midline and secured to the patient. And then again, this is added support over the withers just to help keep the splint in alignment. It provides rotational and bending stability for humeral fractures, and it can be used in calves and small ruminants. It can't be used in adult cattle because they're just too big for it. Aftercare, the splints or cast should be worn until there's a palpable callus of the fracture site and clinical stability, which usually is 5 to 8 weeks. That little lamb I showed you earlier where we just put it in a splint about 2 weeks later, it already had palpable stability and was doing really well. But since it was a week old when it came in, the younger they are, the faster they want to heal because they have a lot of bone turnover because they're growing. But in general, it's about 5 to 8 weeks. And then after they're out of the cast or the splint, you're going to put them in some type of wrap. If it's a cast, you go cast, splint, bandage, nothing. If it's a splint, it'll go splint, bandage, nothing. Because again, you want to slowly wean them off of that support, give their tendons and ligaments time to get used to full weight bearing and things like that. And you do that over the course of about 3 to 6 weeks to give their body time to adjust. And then they can gradually return to their normal activity, which for most of the patients is grazing because they're either out in a pasture or in a dairy barn. Complications, again, those pressure sores. If the cast or splint fails, a closed fracture could become open. Some animals don't like their splints or casts and won't get up, which is a whole other problem that can lead to myopathies and neuropathies and muscle wasting. They can also fracture at the top of a cast, so you have to be careful with that. They can also have delayed union where the fracture just isn't healing or poor fracture alignment. And then that laxity after the splint or cast removal, or if they break or damage anything. And sometimes despite your best efforts, and even if the fracture looks like it has healed well, they still might have chronic lameness in that leg. So the next type of thing is an external skeletal fixator, which we can use again in our small ruminant and cattle species much more than we can in horses. Advantages is easy return to function. You can access and manage any type of soft tissue wound. So if it's an open fracture, which you can't do if there's a cast on the limb, it helps preserve the local blood supply and the local healing factors. And the design is pretty flexible, so you can move it around the limb depending on what bones are affected and the fracture configuration. And there's relatively few implant complications. Disadvantages is it doesn't always have the best fracture reduction or alignment, and there is no type of interfragmentary compression, so no compression of the bones. That you want some compression. That's what helps stimulate healing of the fracture site, and you don't really get that with external skeletal fixators. It's also a less rigid stabilization compared to putting in plates and screws, so that can have some increased post-op management that's required. They can also have pain associated with the pin to bone interface if there's micromotion, and then the implants can fail, which is a potential complication. Anytime you put implants in bones is that they fail before the fracture is fixed, or just sometimes they fail in recovery after you're waking them up from anesthesia. So when do we use these? Fractures that have a lot of soft tissue trauma, or fractures that are open or require wound management. So there's 3 different types. Type 1 is a unilateral, so there's just one bar. So it's on one kind of plane of the bone. So this is a type 1A and a type 1B, but they're unilateral frames. There's less resistance to compressive and bending forces with these because they don't help with multiple forces along the bone. A type 2 external fixator is bilateral, so it's on both sides of the bone. So you can see there's bar on the lateral and medial side and then pins across. These have more rigid compression, and they prevent more rigid against bending forces as well. And these allow treatment of open or contaminated wounds. And then a type 3 external fixator is in multiple planes. So this one is dorsolateral and medial. This one is a semicircular fixator, so it's going around almost the entire circumference of the limb. And so these are the strongest and the most stable type of external fixator, and has the most strength against compressive and bending and rotational forces. we don't use these very often, but they are options. There are some high value cows and bulls that people will want to try this on. Something else that can be used that's more common than the external fixers is a transfixation pin cast. So these can be used for comminuted closed fractures that would just collapse on themselves if it was a simple cast. So like this fracture in this image, if you just casted it, as soon as the animal stepped down, these fracture lines would continue to propagate, or this one here, it would continue to displace because there's no stabilization in either one of these fractures. And so what the transfixation pin casts do is they help overriding of those fracture fragments. There's two types. So in this image up here, this is what they would consider a true transfixation pin cast. So there's 2 pins above and 2 pins below the fracture. So it will fully prevent the fracture from compressing on itself. So when the animal stands, the weight gets distributed to the pins and the cast that's around it and not to the bone. This one is what they call a hanging limb transfixation pin cast because the pins are only above the fracture. And this will just depend on where the fracture is in the limb, if you can do pins above and below or just above. And so this one doesn't prevent the bottom portion of the bone from going proximally like it would here. But the whole point with the transfixation pin cast, you put pins through and then cast the area, and the weight of the animal is distributed to the pins and the cast and not directly onto the bone. For this one, the foot has to be incorporated into the cast. For this type, it doesn't necessarily have to be in the cast. There are different types of pins that are used. This chart here just says the diameter of the pins based on the weight of the animal. And we try to put the pins in at 30-degree angles. You don't want to put them all on the same plane because that puts too much pressure on the bone and they can actually fracture at the pin site that way. So we put the pins in at a little bit of an angle around the bone to distribute the forces a little bit better. This is done under general anesthesia using aseptic technique. Usually the animals are in dorsal recumbency. And one of the things to remember when we're placing plates and screws and things like that is you want to minimize the heat of the drill. And for this, you want to place pins at a slower speed, and that will decrease the amount of heat that is formed when you're placing them. For these casts, they're maintained for 6 to 8 weeks. In adults and calves, it's 3 to 4 weeks. If any pins loosen, they need to be removed at the time of cast change or sooner. If you still need the transfixation pin cast for support, you can put a larger pin in, depending on what you may need to do. And again, after we remove the cast, you do cast, splint, bandage, then no bandage, and then they can return to normal exercise, wean them out of this type of coaptation before you turn them back out. So complications that we can see with this is early pin loosening, pin bending or breaking. So if you look closely in this image with this pin, the line of the pin goes here, and then there's a little step up, and there's the rest of the pin. So this pin broke inside the bone. This is a ring sequestrum, so the bone around the pin died. And so this is what the result. You can see these indentations here are from the threads of the pin. This I just put in, it's a really cool case from, when was this? 2014. I won't go through everything, but I'll just show you the images. But it was an 870 kilogram bull that came in that had a really bad fracture. And they were able to put him in a transfixation pin cast. They did a full limb cast and put the 2 pins in the radius and then incorporated his foot into the cast. And he had some complications throughout. They had to change the cast several times and kind of change a little bit of what they did. But by the end of it, his fracture actually healed pretty well. So you can see all the new bone formation. And then in 7.5 months later, he was back breeding again. So it was a long recovery period, but he actually went back and his leg looks pretty good. So this can work even in really, really big, heavy animals. Not all of them, but it is possible. So that's just kind of a cool case report from several years ago in a really large bull where this worked. So next, looking at internal fixation versus conservative treatment. Again, many fractures in these animals are amenable to casting or things like that versus having to put plates and screws. There is a perceived lower cost for using cast versus any type of internal fixation, which depending on the type of injury is true. But sometimes if they need multiple cast changes and things like that, it could take longer to heal. It may end up actually being more expensive in the long run. It just kind of depends on what the fracture is and what the owners are willing to spend. Internal fixation is usually the treatment of choice for fractures in very valuable patients or show cattle, or fractures that aren't going to respond to a cast or some type of external fixation alone. So there's a difference between internal fixation or some special considerations for calves versus adults or say young animals. So they have a lower bone density and thinner cortices. So their bone is weak at that bone implant interface. So that's why we tend to go with cast more with them. And you just have to let the owners know that they have a higher chance of things slipping out and not working as well as we would like. The big thing is screw pull out because again, their bone is softer, so the screws don't hold quite as well as they do an adult bone. Washers and bolts can be added to try to help with that pull out risk, but it's just something to note. For calves, Salter-Harris fractures, type 1 and 2 are most common. And the metaphyseal region is the most common site for fractures. And for calves, 60% of the tibial and femur fractures are in that location. You also have to think about concurrent disease. So like that calf I mentioned earlier with the open fracture that also had a fever, that makes him a poorer candidate for internal fixation because he's systemically ill, much higher chance of the implants getting infected. If the calves also have an infected umbilicus and there's bacteria running around their bloodstream, if they have pneumonia, things like that. So looking at other disease processes versus adults usually just have a fracture. They don't necessarily have systemic issues going on as well. And for adults, as I said earlier, the implants that we use are designed for people. And again, the biggest person is a small horse or a small cow. So the implants may not be strong enough. As much as you want it to work, it may not happen. So in this image, this is a tibial fracture that was treated. It was what we call double plated because there's a plate here and a lateral plate and a cranial plate. And you can see when it stood up, it bent the plates and the fracture broke again or the bone refractured in recovery because they just weren't strong enough. So that is always something we have to consider. Sometimes we really want to help them, but they're just too big. And unfortunately, we don't have metal plates that are designed for animals as big as we treat. If there's any disruption of this soft tissue or skin, there's increased risk for infection, and the infection can translate or get to the plate and the bone and the screws, which could infect the bone and loosen everything up. So there's decreased chance of success and open fracture, things with a lot of soft tissue damage. Bone grafts can be helpful for repair sometimes. And then just in general, because we're dealing with ruminant species, there's a risk of regurgitation or ruminal distension or bloat because they're under anesthesia. So those things to consider, especially in the post-operative period. Plates and screws, so the principles to apply them. I'm not sure how much you all have gone through like on the small animal side with fracture repair and how plates and screws are placed. So I didn't really go into it in this lecture. If it's something you want me to do, please let me know and I can do it for the equine lecture. I don't know how much you all have been taught in your classes about it. So for horses and cattle, because they're so big, almost always we're again, what I call double plating, where there's a lateral and a dorsal or cranial plate, because we're trying to support the bone into planes to have as secure of a fixation as possible. Because again, they have to stand up and walk on their fractured leg as soon as they wake up from anesthesia versus people who can lay in bed and do slow recovery. We try to fill in every single hole in the plate. The only reason we wouldn't is if it's crossing a fracture line. You always put the plate on what's called the tension surface of the bone, and that's how you get compression across the fracture line. And the main two types of plates, which again, I'll talk about a little bit more in the equine lecture, that we can use are dynamic compression plates or locking compression plates. Intramedullary pins are another option. These are used much more commonly in calves and younger animals. And it's just putting pins through the medullary cavity. It doesn't have any really stability and torsion, so twisting of the bone, and it doesn't really resist collapse of oblique or comminuted fractures because you're just putting pins straight in. There's nothing going through the bone on the sides to try to keep everything stable. There's wires, pins and wires that can also be used. You can see in this one, there's pins and some wires also going around the fracture to try to keep it stable. And then stymon pins are the most common type of pin used. And again, these are for humeral or femur fractures. And we usually do what's called stack pinning, where you're doing more than one. So again, in this image, there's at least 3 pins going into the bone because you're trying to fill up the entire medullary cavity to give as much support as possible. Complications, pain related to the instability, the pins can migrate and they can get infected. Interlocking nails are more the treatment of choice, especially for femur fractures. It's a similar principle to the pin, except you also put nails across the bone. So there's a pin in the bone and then nails that go across so that it has more stability than just putting things into the medullary cavity. It has some compressive stiffness, but it's only 15% of what is an intact bone. And then it can fail at points where there's empty screw holes, so you may not put the nails across every screw hole that goes into the interlocking nail. But again, it is the method of choice now for femur fractures and foals and calves because it has the best stability, because in that area, it's very hard to put a plate and screw, and this is much easier to say much easier. It's easier to do than the plate or the screw. Okay, so a couple cases, because I know that's a lot of information that was thrown at you. But for case 1 is a 1-day-old Holstein heifer calf. She was a dystocia and was pulled with a calf jack. And so this is an image of a calf jack. It's an instrument that goes over the back of the cow and then puts pressure on their hind legs. And then there are chains connected to the calf's legs and then to the jack. And they basically push and pull to slowly have traction to pull the calf out. It's been known to cause fractures in the limbs of a lot of calves because it can be really, really rough on their legs. So this is, her name was Fierce, and this is the fracture when she came in. So she has a distal radial and ulnar fracture. This is the DP view and the lateral view. And so what we did for her, again, as we talked about earlier, in young animals, they have soft bones, so it's very, very hard to put plates and screws in. So that wasn't really an option for her. We recommended a transfixation pin cast, but the owners declined doing that for monetary reasons. And so we just put her in a cast. We told them just to stall rest her, and they didn't follow our guidelines as well as they should have. And so she came in a week later and had blood on the inside of her cast. This is a picture I showed you all a little bit earlier. And so this is what her fracture looks like now. And so there's gas opacity on these radiographs, and you can see where the bone is overriding. And so this is that risk I was talking about of just putting a cast on. It doesn't prevent the 2 pieces of bone from going down on each other every time she took a step, which is why we wanted to put a transfixation pin cast on to try to prevent some of that compressive and concussive forces. So this is what happened with her leg. The owners still didn't want to spend a lot of money, so we put a new cast on, and she never came back for any rechecks or additional cast changes. However, the owners contacted me about 6 months later, and she was doing really well overall. She had a bit of a flexural deformity in her good leg, but it eventually healed over time. And they contacted me actually a couple weeks ago, and she's doing really well. So this fracture is from 3 years ago, and she's had a calf now. So again, cattle are amazing. They want to heal. So she, despite not doing the best treatment that we thought she should have gotten, she still ended up healing well enough to go on to have babies and be a dairy cow. Okay, I know it's a lot of information. So any questions on the cattle before I move on to camelids and small ruminants? There's not much left, I promise. We're almost done with this lecture.
Guy has any question? There is a question in the chat, Dr. Jordan.
Yep, I see that. So we are actually getting ready to talk about limb amputation. So I'll answer that question shortly. In bone graft, it just depends on the type of fracture. We tend to use them more in comminuted fractures. We can use the bone graft to kind of fill some of those spaces and also just try to help promote new bone formation to help fix the fracture. But limb amputation is coming up for the camelid small ruminant section. So we will talk about that in a few minutes. So the advantages to small ruminants and camelids is they have a relatively low body weight. So their body weight is more similar to people. So our implants are designed for their size, and they are really, really good at walking on 3 legs. So they do really well post-operatively, having a cast on, internal fixation, things like that. They also tolerate external coaptation devices really well, and they rest a lot, especially camelids. They like to cush and lay around. So again, they rest their bodies a lot better than horses do and give themselves time to heal. And as I said earlier, they're classified in our country, or my country, as secondary food animal species. So we have a little bit more wiggle room on pain medication and antibiotics that we can give them. We still can't give them phenylbutazone. We're still limited to meloxicam or Banamine from a pain management standpoint, but we can give them more antibiotics than what we can give cattle. So there's a little bit more options there. Emergency management, so doing a thorough physical exam, and you want to assess for blood loss and shock, and then stabilize the fracture, which again, I'll talk about that more in the equine lecture. This is just some sedation options for them. One we call here a camelid cocktail. It's different for alpacas than llamas, so you want to make sure you know the species that you're working on, because the doses are a little bit different. The llamas have a lower dose than the alpacas. I did put this in mg per pound because I meant to switch that to mg per kg for this lecture, but this was the lecture for my students here. And then goats, diazepam or midazolam and butorphanol was really, really good. There was a quick question of what tissue do we use for the bone graft? The main area we take them from in these species and also in horses is the sternum. It's a really easy area to get to, especially if they're in dorsal recumbency. You just make an incision over the sternum and use a certain instrument, usually a GM sheety or potentially a trephine or something, to open up the external bone of the sternum and then pull out the marrow material and then use that as the bone graft. So the sternum is the most common area. You can take it from the tubercocci as well. I've also done that. So those are kind of the two areas. So if they're in dorsal recumbency, it's usually the sternum. If they're in lateral, you can do the tubercocci to get the bone graft. And again, that's cattle, small ruminants, horses. Those are locations we can do that. Healing time, so crias, the young camelids, physeal fractures heal in about 4 weeks, and non-physeal fractures about 6 weeks. Again, the younger they are, the quicker they heal, because that's just what their body's just producing bone and trying to grow, so they heal really well. Adults about 8 to 10 weeks, and in general, it's longer for comminuted fractures, especially with severe soft tissue damage. And adults, if they do have osteomyelitis, it's easier for them to overcome that than in the younger animals, because again, younger animals usually have or can have other problems going on besides just the fracture if they have, again, an infected umbilicus, pneumonia, things like that. And in general clinical union, so what we say, okay, this fracture appears stable, usually occurs at least 2 weeks before radiographic union. So kind of what I was talking about earlier, if the fracture feels stable when you're palpating it, because some of our clients don't want to pay for radiographs multiple times, so we're just having to use our palpation and feeling, and if the fracture is stable on palpation, then we can move forward with coming out of a cast and going into a splint or things like that. And then, as with the other species, open fractures have a poorer prognosis than closed fractures, but the plus side with the camelids and the sheep and goats, because they're smaller, amputation is actually an option for them, which is not for full-size cattle. And there are a couple of people who do amputations in horses, but that's a whole other thing to talk about. So again, casting is something we can do for external coaptation. If they get cast sores, camelids will just stop walking on their leg. They will just hold it out and drag it instead of walking on it. So if you see that, definitely check for cast sores and see if something else is going on. Transfixation pin cast can be used on them. Thomas Schroeder splints, a Velpo sling, which is what this Cria has on right here. So her limb is bent at the carpus and then just attached to her body, so she's not putting any weight on it. This Cria was a radial fracture repair that I fixed, and we did this to help prevent her from walking on it and disrupting some of the repair because it was comminuted. This is something that's used in small animal as well. And external skeletal fixers can also be used on them. Not very common, but it is still an option. Internal fixation, because they're smaller, we can use a lot of the instruments that are used in small animal. So the smaller size plates and screws. And then again, the intermedullary pins or interlocking nails, like I talked about earlier. Again, the big thing with them that's another option we can do is amputation and prosthetics. And so because they have a lower body weight, they can handle ambulating on 3 limbs. So limb amputation, you can do it if primary fixation method fails, if there's a lot of infection and trauma that would preclude doing other types of fixation, or if that's what the owners want to do, they don't want to pay for internal fixation, rather just amputate because honestly, it's a cheaper option. The big thing, if they want to try to do a prosthetic, is when you amputate, you want to leave enough skin to fold over the stump of the bone so that there's skin covering for where the prosthetic will go. And again, this for a prosthetic, it can only be on a long bone. So if you have to take the entire front leg off, they can't get a prosthetic. But if it's where you can amputate at the level of the mid radius or the mid tibia or the mid metacarpus or mid-metacarpal or metatarsal bone, then you could fit them for a prosthetic. And at least in the US, there are several companies that actually specialize in this now. I don't know if you have it in your country, but we have what we call food animal rescue groups, people who take animals that would be intended for slaughter or that the owners don't want to treat them, things like that. And they'll actually rescue them and then bring them in and have us amputate legs or do things with severe injuries and then fit them for prosthetics. It's quite popular in certain areas of the country. This is just a schematic of a limb amputation. You're going to do, it's a similar step as what you would see in small animals. When I do the limb amputations, I look in the small animal surgery book and do it that way. And this is just showing the skin incision is enough to cover the bone stump, and that way you can fit it with a prosthetic later. This question, do we use the same medication for surgical anesthesia in cattle? I will get to that question in a few minutes and we'll go over that. Aftercare, there should be a quick resolution of clinical signs after amputation and then medicate as needed from antibiotic standpoint, pain medication standpoint, and then physical therapy for the support limb because they can get support limb issues with the amputation. So The drop fetlock that we saw earlier, they can just be painful. They can get angular limb deformities. This patient is blue, and I will give you her full story shortly, but she, on her good leg, had laser treatment done and things like that. And that actually helped with her pain management and allowed her to decrease the amount of meloxicam she was needing to stay comfortable. So using K lasers is the type that we would use for that. It's a sports medicine thing. And then as you can see, she eventually was fitted for a cart to also help her. Complications, again, support limb, they can get angular limb deformities, have tendon breakdown and laxity. They can have complications at the surgical closure site. It can dehisce. They can get excessive granulation tissue formation, which can delay healing and can also delay when they can get a prosthetic placed. And it's the same thing with people. If people have sores when their limb's been amputated, they can't be fitted for a prosthetic until those have healed. And then for young animals, they'll have to be refitted for prosthetics as they grow. So this is a specific company in the US, and you can see all of these goats this one has 2 prosthetics on. So it makes them very specific for different animals. You can debate the ethics of this. Should we be putting prosthetics on both hind legs of a goat? There's some ethical discussion. We won't have that here, but it is something to think about. But they at least all seem happy and healthy at this point. But like I said, there are companies who do this here in the United States. So this is Blue's story. She was a 2-month-old lamb and she could not bear any weight on her left front limb. She had a congenital defect in her elbow. I worked with her at a different university. I don't have access to her x-rays, so I can't put them up for you. But basically her elbow joint in this leg didn't fully form. So she wasn't able to use it because her joint didn't work. And so the treatment options for her were limb amputation or euthanasia because there wasn't much else we could do. But because it was so high up, we had to do a full limb amputation. She is actually with a food animal rescue group. And so you can see the swelling in her elbow joint here too as we clipped her and prepped her for surgery. And again, I used the small animal technique to, we removed her scapula and everything. And this is her in the post-op period. I will say she loves having her picture taken. She poses anytime a camera is out. So we have great pictures of her. But this was her in the immediate post-op period. At her 1-month recheck, her incision looked great, but we could already begin to see changes in her support leg. So you can see the space between her claws is a little bit wider because, again, all of her weight on the front of her body is just on this leg. You can see it's placed underneath her a little bit more, and she's getting a bit of an angular limb deformity, and her fetlock starting to drop. We did get her fitted. There are limb braces that they have for small animal, and I contacted them and we measured her and got a custom-made support brace for this limb to help with that. She didn't like it very much, and so the owners didn't use it very often with her because it was hard for her to eat grass with it on. 6 months later, she came back, and you can see the angular limb deformity is a little bit more pronounced, and she's got a little bit more tendon laxity here. And since she hated her brace so much, we fitted her with a cart so that she could have some extra support and not put quite as much weight on this leg if she needed a break. And again, you can see how big the space is in her interdigital area from just bearing weight. Blue is still going very strong. She's had a couple other complications that had to be dealt with. She actually, poor thing, only has one eye now because she got attacked by another resident at her rescue farm and that damaged her eye, but that hasn't stopped her. She's a good mascot for the group. She loves people, and she's 3 or 4 years old now. So she did really well with her amputation. And because it was a rescue group, they put a lot of money into her to make sure she got the best treatment possible and was as comfortable as possible. So, like I said, she takes great pictures. She loves having her picture taken. So the question was, do we use the same medications for surgical anesthesia in cattle, camelids, and ruminants? And in general, yes. So at least for the United States, for the the drug laws. The basic things that induce anesthesia is similar to what we use in horses. So ketamine, midazolam, all of those are legal to use. There's just a withdrawal period. We can use butorphanol. They can go on isoflurane or sevoflurane for anesthetic gas. The biggest regulations we have are from the antibiotic and pain medication standpoint. There's certain antibiotics that are legal to use. We just have to have what we call withdrawal periods. So if we use potassium penicillin, it has a meat withdrawal of 28 days. So they can't go to slaughter until 28 days after. Meloxicam is a pain medication. It's COX-2 selective. It's a 30-day meat withhold. For dairy cattle, you also have to know the milk withhold. So ceftiofur is a drug that we can use. In horses, it can be given IV or IM. In cattle and pigs, you can only give it in the muscle. It's illegal here to give it in the vein, but for sheep and goats and the llamas and alpacas, because they're secondary species, we actually can give it IV to them, which is nice. But that medication has a milk withdrawal of 0 days when given IM in cattle and a meat withdrawal of 4 days. So it's an antibiotic producers like to use or like us to use because it has a short withdrawal period. Medications that are illegal to use, like I said, we can't use phenylbutazone or bute in food animal species. Aminoglycoside antibiotics like amikacin or gentamicin, they're not illegal, but the use is frowned upon because their withdrawal period is over 2 years. So we don't use those in our food animal or production species. Chloramphenicol is completely illegal to use. It can cause aplastic anemia in people. So there's a lot of regulations here. Like I said, I don't know exactly what you have in your country regulation-wise for medications, but if you're going to work on these species, you want to make sure you know what it is so you don't give them antibiotics that are illegal, because especially here, you could actually lose your veterinary license and not be allowed to practice anymore if you give certain medications that are illegal. So hopefully that answers that question. And so that's finally the end. I know this is a very long lecture. This is me in Blue, and then this is Kelly, the owner of the farm animal rescue group that takes care of Blue. So any questions? Like I said, I know that was a lot of information. There are some things I'll go over in the equine lecture. So we'll talk about fracture classification, stabilizing certain fractures to transport patients to hospitals and things like that next week. There's just a lot of information to cover with orthopedic stuff, so I was trying to balance it out. If you're interested in learning more about conditions in the feet of cattle, I do have a student lecture that I can just make a PDF format and email it to you, Prad, if you want to give it to the students. If you guys want more information on that, I know I won't have time to lecture on it, but I can send that out as well. So question, in adult animals, do we need to limit movement during fixation? So yeah, for all of these, whether it's a cast or internal fixation, all of these patients are going to be on stall rest until the fracture is healed. So again, the younger animals don't usually have to be on stall rest quite as long, but in adults, we're looking at least 4 months of being rested in a stall while their bones heal. We tell clients that the healing time, at least in English, is related to the number of letters in the word. So bone, 4 letters, 4 months. Tendon has 6 letters, so about 6 months, and ligament could be 8 to 12 for different injuries. That's kind of something I like to tell clients here. So yeah, stall rest until things are fixed. Can we apply ultrasound and other techniques to improve bone and wound healing in ruminants? Ultrasound won't necessarily improve bone healing per se, but techniques that can help, especially with wounds. There's not a ton of studies on the ruminant species, and they're still working on even getting in the equine species, but laser therapy has been used. Again, that K laser that helped Blue with her pain management, but it can also be used to help with wound healing. Again, here's some of the things we have to be careful with for legal reasons. Now, ultrasound and laser therapy isn't going to be anything systemic, so there's no laws against that. Trying to think of anything else. Like the therapeutic ultrasound, we're using the ultrasound to deliver heat to areas to stimulate blood flow. We could use that in our food animal species. The big question with cattle is how well is that even going to work because their skin is so thick. There's limited studies in horses on how deep therapeutic ultrasound can go and how deep the heat can penetrate for tendon and ligament injuries. And it's not very far because their skin is thicker than ours. That's actually something I'm interested in for my own research because I really like sports medicine. But there's no studies that I know of looking at that type of treatment in cattle because, again, their skin is so thick. I don't know that a therapeutic ultrasound for the heat would even be able to penetrate through their skin. Now, small ruminants have thinner skin, so there's definitely a possibility that could help. I hope that answered the question. Anything else? Any other questions?
Well, it doesn't look like there is more question. Dr. Jordan,
Okay.
Are you going to continue another lecture or?
Am I going to continue what? I'm sorry.
Are you finished or are you going to continue the lecture about urinary tract surgery or not?
I do have that one I can pull up. I don't know time-wise because you said that this could only go till 10:30. Is that correct?
Yes.
Okay.
You maybe Dr. Suwarak, are you there, Dr. Suwarak?
ไม่แน่ใจว่า sorry in Thai ไม่แน่ใจว่าวิชา
เขาอยู่ถึงเพราะว่า 10:30 เด็กๆจะต้องมีเลคเชอร์ต่อ
ใช่
AI ฮะแต่ทีนี้มันจะเหลือของ urinary tract surgery ของสัตว์ของโคกระบืออยู่ว่าจะเอายังไง
ต่อก็ได้
แล้ว AI จะไม่สอนนะสักถึงสัก 11 โมงได้ไหมถ้างั้น
เดี๋ยวผมถามอาจารย์ต่อข้างๆเนี่ย
Could you read just a little bit, Dr. Jordan? We are discussing about the terms for today.
Yeah, sure. And if you want, if you want me to talk about the most common urinary problem, which is urolithiasis in goats, I can just skip to that section and just show that.
Sorry.
Okay.
Yep. Our staff said they have time until 11 o'clock.
Until 11?
Yep.
Okay.
So yeah, you may want to continue lecture for the urinary tract problem.
Okay.
Thank you.
Can you see the lecture?
Nope.
No. Okay. Let me try again. Did this yesterday too. Can you see it now?
Yes.
Okay, good. I don't know why it keeps doing that. So I will go through until 11. So I tried to do some of the most common things and just some things to consider. So general considerations when we're doing surgery in our food animal species. A lot of the time we're doing it under, especially cattle, they're standing, maybe lightly sedated if needed. And our ruminant and camelid species are going to be under sedation. So you're going to need to do local blocks to do your surgical procedures because they're not under general anesthesia. And the most common medications we have are lidocaine or carbocaine. Carbocaine has a longer duration of action, so it'll last about 4 hours versus lidocaine's about 2 hours and it burns a little bit less on injection. It is a little bit more expensive, so a lot of times we're still just blocking with lidocaine, but carbocaine is an option. It can have neurologic side effects if you give too much, which is very, very, very important in sheep and goats. So the normal safe dose for lidocaine or carbocaine is 10 mg per kg or 10 milligrams per kilogram in cattle, horses, things like that. Sheep and goats, it's half that. So it's 5 milligrams per kilogram. So you have to be very careful to make sure you don't overdose your patients. This can be very important in small goats that come in. We used to have problems when the medicine service would take in goats and then use some lidocaine to put the catheter in. And then we had to do a C-section and they used 0.5 ml of lidocaine, but the goat only weighed 12 kilograms. And so then we only had 1 ml of lidocaine we could safely use to anesthetize our surgical site. So you want to be very careful with that and think about that for the sheep and goats, especially if they're very small and you just can't use a lot because you could cause them to have some neurologic side effects. So it's just a really important thing to remember if you're working with them. Another good thing just to know how to do if you're working with cattle, I did urogenital stuff for this lecture. So the internal pudendal nerve block is something that will, especially in cattle, will help to relax the penis so it can be exteriorized for you to evaluate, and also can anesthetize it a little bit as well for some procedures. So the steps is you're going to palpate the ischiorectal area, and you're going to clean and clip that fossa and locally anesthetize it, which is what this person is doing here. And then you put a 14 gauge 1.25 centimeter needle through that area of skin shown here. And then at this point, you place your hand in a rectal sleeve and put your hand in the rectum to the level of the wrist, and you're going to hold your hand sideways so you can palpate laterally to identify a soft depression and the sacrosciatic ligament. So like how this hand is going in, because you will actually be able to feel the needle pass as you anesthetize the nerve. So the next step, we have the 14 gauge needle here, and then we're going to take a long spinal needle and insert it into that 14 gauge needle. That's basically a stylet essentially, and you'll advance it all the way in. And the importance of having your hand in the rectum too is you want to make sure that the needle doesn't go into the rectum. You don't want to penetrate the rectum while you're doing this. And so the needle is directed cranioventrally, as you can see how this person is doing it. And then once you advance it all the way in, you'll inject around 20 mils of lidocaine. And then you'll pull the needle halfway out and redirect it caudodorsally and inject 10 more mils of lidocaine. So you can see the angle of this hand, they've drawn out, and now the needle's angled a bit more dorsally to finish anesthetizing around that nerve. And it takes about 30 to 40 minutes for it to take effect. This is really, really useful if you're having to do surgery on a bull's penis or anything like that, because it just relaxes out for you. So you're not fighting them trying to pull it back up. So it's a really good block to know. So first we'll talk about male urogenital conditions. This is just a brief overview of the anatomy. So the first thing I'll talk about is castrations. I'm just going to briefly discuss this. So calves less than 1 month old, lambs or kids, you can manually restrain them in lateral recumbency. It's important to do local anesthesia. 30 years ago, they would do this in some of the young animals without any anesthesia, which is now considered inhumane. So make sure you have some local block for this procedure. And so for these smaller animals, the distal portion of the scrotum is grasped and pulled distally, and then you squeeze the testicles proximally. And then you just cut the distal portion of the scrotum. And then you apply traction to the testicles and manually reduce the fascia away from them. And then exteriorize the testicles, and you can either ligate them with suture and then transect, or use emasculators, which is this instrument, to crush and then to crush the vessels and then cut the testicles free for castration. If they're over 150 kilograms in cattle, they're normally in a standing chute with sedation. A ram or buck They can either be in a small ruminant chute, which is very similar to what cattle are in, but just a smaller size, or they're sedated and put in lateral or dorsal recumbency. The procedure is basically the same, or the other option is to make a vertical incision on either side of the median raphe like you would in a horse. Because these animals are bigger, you want to ligate the testicles before you emasculate or transect them just to help prevent bleeding. I'm also going to talk about castration in pet pigs. I'm not sure in your area, but in the United States, pot-bellied pigs are an up-and-coming pet that people have. I have some clients, the pigs sleep in the bed with them like a dog or a cat. So they are very popular pets, and they have a little bit more interesting way of being castrated. They're done either under heavy sedation or usually at a hospital under general anesthesia. It can be done in lateral or dorsal recumbency, and you'll clip and prep the scrotal area, which is down here. And the incision is you can either do it on either side of the median raphe or the cranial-ventral aspect of the scrotum. I tend to do it almost like a dog, where it's almost pre-scrotal near the inguinal rings. And you'll isolate the testicle and remove them as normal for a castration. But the big thing in pigs is once you isolate the testicle and spermatocord, you actually want to twist it several times. And that's to move any potential abdominal viscera that could be in the inguinal canal back into the abdomen. So you can see the spiral and the spermatocord here, again, because you twist it and then you always ligate these because they're very prone to scrotal hernias. So you want to make sure you ligate this area so they can't get an inguinal hernia after this procedure. And then after doing that, you also close the inguinal ring or partially close it, which is again not something we do in a lot of the other species, but because they're so prone to herniation through this area, it's very important to do that. And then you close in 3-layer, or then close the subQ if you want, and then skin. I always use absorbable suture so they don't have to come back for that to be removed. But the big thing with pigs is to remember you twist the testicle and spermatocord to push abdominal contents, anything that might be in the inguinal canal back into the abdomen, always ligate them. There are techniques for what they call bloodless castration, which causes ischemia of the testes and atrophy and necrosis, and they eventually fall off, which takes about 3 weeks. This is done usually on farm by the producers for very young lambs or kids. I have never done it. They should now have proper restraint, sedation, and analgesics if needed, but if the farmer's doing it, they may not have those things on hand, but it really is considered inhumane not to provide pain medication for these animals. But basically they're taking that rubber band you saw in the previous image, or this rubber tubing, and putting it around they pull the testicles eventually and then put it around the top of the scrotum. And again, it causes necrosis and they eventually fall off. Another common procedure that's done here is creating what they call a teaser bull or a teaser ram. So they have these animals that can detect when females are in heat, but can't impregnate them. So there's a couple different procedures we can do for that. One is an epididymectomy. This can be done standing or in lateral recumbency. You want to clean and prep the area and then do local anesthesia of the scrotum and testes. This is just a basic anatomy reminder where the tail of the epididymis is. And so you'll do a 2-centimeter skin incision over the ventral aspect of the scrotum to the level of the tail of the epididymis, and you'll bluntly transect that or bluntly separate that from the testes and then transect it and close the skin. So here's the incision. I'm pulling the tail of the epididymis out, and then this is transecting it from the testicle. And the point of this is so that they cannot ejaculate semen and impregnate the females. So these are usually lower value bulls that, again, they want to keep the testosterone from. They want to keep the animals to have testosterone so they can detect heat, but not be able to breed them because they may not have a good genetic bloodline or something like that. With this procedure, they need to wait 30 days before they go back out with any females because they can still have some fertility up until like 30 days after the procedure is done. And this is just another schematic to show you how to give you a visual of how the procedure is done. Another type is a vasectomy, which is a removal of a section of the ductus deferens. And again, the purpose is to prevent semen from being ejaculated. This can be done in standing or lateral recumbency. And again, you want to do local anesthesia. So this is a younger steer that's laid down in lateral. The hind leg is tied up around its neck, so it's out of the way, and you can visualize the surgical site. So this one, the incision is on the cranial aspect of the scrotum, and you incise through the skin and the parietal vaginal tunic. And then locate and bluntly isolate the ductus deferens. You can palpate them, and they can be firmer. They're usually firmer than the surrounding structures and kind of on the caudomedial aspect of the spermatocord. And so this is an image of isolating the ductus deferens and the steps to do that. And then you'll ligate in 2 locations about 3 centimeters apart, because you want to take about 3 centimeter portion, remove that for this procedure. And so this is the ductus deferens isolated. So you'd ligate here, and then transect so that you're taking away about this length of tissue. And then close the skin with absorbable sutures. Again, I almost always close with absorbable, so I don't have to go back and take it out, especially when it's underneath the animal. Here's another schematic drawing just to give you a different type of visual. And then this is the procedure being done, I believe, in a sheep. And so again, you can see how it's isolated. They ligate both sides and then take a decent amount out. Another thing they can get, especially in cattle, are penile tumors. This is where that pudendal nerve block comes in handy, so you can get them to exteriorize their penis and really evaluate it. It's common in young bulls that are housed together. Most of the time it can be removed surgically in the standing animal. And again, that pudendal nerve block to relax everything out. And it can allow some anesthesia of the penis, but a lot of times you'll still just want to do a local block just to make it more comfortable for them. And in case the pudendal block didn't fully anesthetize the area. A lot of time the papillomas are pedunculated, like in this image, so you can just put traction on them and find where the attachment is and just easily transect it sharply with a scalpel blade. And then that's about all you need to do. If it's a bigger area, you may need to suture the defect. And then because it's on the penis, they need to be sexually arrested for about 3 weeks so they don't cause damage to the area. Another thing that can occur is called a persistent frenulum, which is incomplete separation of the penis from the lamina interna of the prepuce, which you can see in this image. And usually should be completely separated by about 9 months of age. If it's not separated by the time they're a year old, it's considered persistent and it would need to be treated. It is considered an inherited disorder, so that's something to think about if it's in one of the breeding bulls, but it's something that's easily fixed. And if everything else about the bull is fine, they're probably going to continue to breed it. But if they have this condition, because the penis can't fully exteriorize and the tip actually gets pulled up, they can't breed the cow, so it does cause problems with that. It's easily corrected surgically, so you can do it standing. Again, that pudendal nerve block to relax the penis, locally anesthetize the surgical site, and then prep it for surgery with either dilute chlorhexidine or dilute betadine solution, and then clean it with saline. For this type of thing, you wouldn't want to use alcohol because it could burn. So clean it with the chlorhex or betadine solution, not scrub because that will burn less, and then wipe it off with saline instead of alcohol. And basically all you have to do is double ligate where the persistent frenulum is and then transect between the ligatures. The reason we ligate, and I'll actually go back to this slide, this arrow is pointing to these vessels that is coming down into the tissue. So you want to make sure you ligate it so that they don't bleed. So double ligate and then transect between the 2 ligatures, and then it's separated out in the condition. This is curative for the condition. They need to be sexually arrested for a week or 2, and then they can go back out with the cows. And again, that's pretty much all you have to do, which is why a lot of times, even though it's hereditary, if the bull is high value and produces high value calves, they're still going to breed and then just deal with the condition as it arises in the offspring. Another condition is preputial avulsion. It's the avulsion of the lamina interna of the prepuce from its attachment. This is the most common injury to the penis and prepuce when semen is collected in an artificial vagina, and they don't exactly know why, but assuming just the damage and friction from the artificial vagina and the penis. There's two treatment options. One, you can let it heal by second intention, just sexually rest them and let it heal slowly over time. But it does take a long time to heal. And if they are a high value bull, if they're not breeding the cows, then they're not doing their job. And so it could be a monetary loss for the producer if it is a high value bull. So the other option is just to suture the defect closed, typically using interrupted sutures. As you can see here, it's the same. So it's this defect here that they just suture closed with simple interrupted suture pattern. They do need to be sexually rested for 30 days and then rechecked to make sure that it healed appropriately and there's no other damage. If it's healing well, another 30 days of rest so they don't disrupt the healing site before they go back to breeding. So those are kind of some of the main genital issues that can happen in males. The big urinary problem that happens in cattle and especially our small ruminant species is urolithiasis. This is the number one emergency I see in goats, especially pet goats. They're pretty much, if it's a male pet goat that's coming in on emergency, it is urolithiasis until proven otherwise, because it is the most common problem that I see on emergency. And so basically what it is urinary calculi form, and it can be single or multiple. And the calculi are mineral aggregates. The composition depends on the diet and the environment. The most common are calcium carbonate, calcium phosphate, and struvite. The struvite is more common in pot-bellied pigs. Calcium carbonate tends to be a little bit more common in the goats. Any of the species can get any of these, but struvite is a little bit more common in the pot-bellied pigs because we are seeing this condition in them as well, and it's all dietary related in the pet pigs. The most common signalment for this condition is a male goat that was castrated at a young age that eats a predominantly grain diet. They may also be eating alfalfa hay, which is high in calcium. And it can occur in goats as young as 7 weeks old. His name was Chester, and he was a 7-week-old goat kid that came in with urolithiasis. So I've treated 7-week-old, I've treated sheep that were 3 years old. So it's a broad range of age. So the reason this happens, and especially with that signalment, is in ruminants, calcium and phosphorus are excreted in the saliva during rumination. Adult cattle can excrete 50 to 100 liters of saliva a day when they're chewing their cud and going through the rumination process. It's obviously less than that in sheep and goats because they're smaller. But when they're eating a grain diet, they chew it, swallow it. It goes into their rumen, to the abomasum, and just through their GI tract. So they're not actually spitting up their cud and chewing it again and actually truly ruminating. And so they're not getting rid of that excess calcium like they would be doing if they were eating grass and hay. And so that increased calcium intake causes increased calcium in their blood supply and what's going into their kidneys, and that results in this stone formation. So a lot of this is dietary management. A lot of times what happens, as I talked about earlier, male goats are much less valuable than female in the dairy goat industry. And so people get the male goats and they're told to feed them like the female goats, and they get way too much grain, and then this occurs. Another reason why they're more prone to it is testosterone helps increase the diameter of the urethra. When goats are castrated early, there's less testosterone, so their urethras are narrow, so they can't pass the stones as well. But it's a bit of a balance with sheep and goats, because once they hit around 6 months of age, their scent glands develop. And I don't know how many of you have smelled an intact goat or sheep, but they smell terrible. The scent glands, at least for humans, it's not a pleasant smell at all. And if they're castrated after those scent glands develop, the smell doesn't go away. So that's why they tend to be castrated earlier, because if they're castrated before 6 months, they don't develop the scent glands and they don't have that what we would consider a bad smell. So that's why they tend to get castrated earlier, is more for the scent gland issue. But because they're castrated earlier, their urethras are smaller and stones are prone to getting stuck in there. Ruminants also have the sigmoid flexure, as you can see here. So their urethra does this weird curve, and it's a great spot for stones to get stuck because it goes from a big area to a narrow area as it goes around these turns. And then also sheep and goats, they have a urethral process at the end of their penis, which is this area here. So it's a lot narrower and stones tend to get stuck in that area as well. So again, the stone formation results in obstruction of the urethra as they're passing out of the bladder, and it's more common in castrated males. The distal aspect of the sigmoid flexure is more common in steers and bulls. The urethral process and distal sigmoid flexure is where it tends to happen in sheep and goats. And then the sigmoid flexure or the distal penile urethra in pigs is the common locations for these stones to get stuck. Clinical signs, straining to urinate, they may be depressed, especially if their bladder has ruptured, or if they have severe azotemia, they may look bloated. Goats especially just will scream constantly, vocalize constantly. And so that's also a indication that something is wrong. The way this goat is standing, his hind legs are out behind him and his front legs are a little forward in what we call a parked out stance. And they may stand like this to try and urinate and then nothing's coming out and they're straining and vocalizing. Diagnostics to perform. A physical exam, they usually have a high heart rate, high resp rate. They shouldn't have a fever. It's always important to do blood work because, again, it's a urinary blockage. So a post-renal azotemia. Some of them I've had, the worst one I had, I think, had a BUN of over 100 and a creatinine of 14. So they can have very, very bad renal abnormalities and electrolyte abnormalities that you need to treat. One, to make them stable for anesthesia for surgery and just to make them systemically healthy. Abdominal ultrasound is the main diagnostic tool that I use looking for a distended bladder. The bladder is usually going to be 8 to 10 centimeters. And this ultrasound image, they're actually able to identify the urinary stone. I've honestly never been successful finding one on ultrasound because usually for the goats, it's in the urethral process. So that's not an area that's easy to ultrasound. So the main thing I look for is a big distended bladder or a fluid-filled abdomen if their bladder has ruptured. Sometimes you can take radiographs as well, which is what was done in this animal, and there's stones in the bladder and they can see some in the urethra. You can also do contrast radiography if you can exteriorize the penis and put contrast in to see if there's any blockages. A lot of times the clinical signs and the ultrasound with the enlarged bladder are all you need to know, so we don't really need to do the radiographs. And struvite stones won't show up on radiographs anyway, so they could have stones that you can't see. Treatment options, sometimes you can treat them non-surgically, especially in sheep and goats if the stones are in their urethral process. So the first thing that I do during my exam, if I suspect they're a blocked goat, is a urethral process amputation, because I usually have to sedate them to do the ultrasound as well. So we do heavy sedation with butorphanol and either midazolam or diazepam. The benefit of doing midazolam with butorphanol is you can put them in the same syringe. Diazepam and butorphanol have a reaction together and actually precipitate, so you have to give those two separately. You can't put them in the same syringe. And the easiest way to exteriorize the penis is to put the sheep or goat in the sitting position, as you can see in this image. And then you'll put pressure on the prepuce and push down, and then I inject some lidocaine into the preputial opening, and then use Alice tissue forceps to grasp the penis and slowly exteriorize it. And then you isolate the urethral process and amputate it with scissors or a scalpel blade. This can be a lot harder than it sounds, especially if the goat or sheep is resisting. Sometimes it can be very hard to pull out. The other recommendation I give is to, when you amputate the urethral process, make sure your mouth is closed and that it's not pointed towards your face, because if they have a lot of urine blockage and it is because of a stone in their urethral process, once you amputate it, a lot of urine can spew out. So just make sure your mouth's not open and it's not pointed at your face so you don't get urine all over yourself. If that fixes the problem, you're then also going to do some supportive care for the electrolyte abnormalities, fluid diuresis if they need it for the azotemia, and try to get their electrolytes back into a normal range. This is just a schematic of what the urethral process looks like, and here's a picture of the urethral process amputation. You can see that part of the distal end of the penis is necrotic, which can happen with the urinary blockages. But this right here is the urethral process, and they're just cutting it off with a blade. Treatments for this, one is a perniourethrostomy, where the penile urethra is open and sutured to the skin to create a permanent opening. This schematic just shows the anatomy of what you're going through. So the bulbospongiosus muscle to get to the penis and then to the urethra. This, again, creates a permanent stoma for urination and is considered a salvage procedure. It's an ideal procedure if the urethra distal to the area is ruptured. But you cannot do this if the animal is intended for breeding, because since you're opening the urethra, they won't be able to breed anymore because semen will come out of the urethrostomy site instead of the end of the penis, so they won't be able to impregnate anything. The biggest complication is stricture formation at the site, so it just closes down and then they get reblocked. This procedure is not really done anymore. There's better surgical options, which I'll talk about shortly. To do this procedure, this is for the description for cattle. It'd be a little bit smaller incision for a small ruminant, but a 10 centimeter vertical incision on midline about 5 centimeters below the anus. And then you bluntly dissect between the muscle of the bulbospongiosis, and there's a palpable urethral groove deep to the muscle. You'll exteriorize that portion of the penis, and then you'll incise on the midline of the penis to expose the urethra. Sorry, that was my puppy. I heard something. After the penis is exposed and you incise it down to the urethra, you incise the urethra, and then you suture the urethral mucosa to the skin, usually in a simple interrupted pattern. So this is the incision in the penis and the exposed urethra. And then here, the urethral mucosa is just sutured to the skin, and then the skin above and below is just sutured closed, because obviously the incision that you make is bigger than what the stoma will look like. The most common procedure that I do for blocked goats and sheep is a tube cystostomy. I don't think I've actually ever had to do this in cattle because it's not as common. The urinary blockages are not as common in cattle as it is in sheep and goats. And for a tube cystostomy, a Foley catheter is placed in the urinary bladder via laparotomy, and the purpose is to temporarily divert urine out of the urethra, and that gives the urethra time to decrease inflammation, decrease the spasm around any stones that may be present, and ideally allow spontaneous passage of the urinary calculi. Another benefit of butorphanol when we give it for sedation, sometimes I give it post-operatively as well, not only for pain, but it actually can also help decrease the urethral spasm. So butorphanol is a good medication to have on hand to try to help with the spontaneous passage of the calculi after surgery as well. So this procedure is used in pets and then in animals that are intended for breeding. And also if the bladder is ruptured, you have to go in and fix that. The animal cannot survive if their bladder is ruptured. This procedure is done under general anesthesia, and this is just an image of a Foley catheter. An important thing to remember when you're doing this surgery is always check and make sure the Foley catheter works. So inflate it with sterile saline and make sure the balloon holds and there's no leakage or anything like that before you place it in the animal. And you always want to fill the balloons with saline and not air, because if for some reason the balloon starts to leak or Chester, the goat I told you about that was 7 weeks old, he somehow managed to eat the end of his tube, and we were able to salvage it and not have to take him back to surgery. But because I filled the balloon with saline, the saline just can slowly leak out versus if it was filled with air once, because he chewed it right about here. So the valve that's in these that prevents the fluid from flowing back out, if it had been filled with air, the air would have just shot right out right away versus the slow leakage of the saline. So you always want to fill with saline and not air. So to do this procedure, they're placed in dorsal recumbency and the surgical site is clipped, prepped, and draped. You do a paramedian skin incision in the caudal abdomen adjacent to the prepuce, as noted here. It's usually about 10 centimeters in length, but sometimes it has to be longer depending on how big the bladder is and things like that. Depending on how you do it, you can either make the initial incision, the skin and subcutaneous tissue, and then reflect the skin and prepuce to the side to get to the linea alba, and then do essentially a ventral midline incision once the penis and prepuce are diverted over. Or you can do a true paramedian incision and just incise through the rectus sheath, which is what I normally do. The bladder, once you get into the abdomen, you identify the bladder and retract it out of the incision. And then you put stay sutures on either side of the bladder to keep it out for the procedure. I always use a cruciate pattern instead of just doing an interrupted. The reason I like cruciates is it distributes the force a little bit more around the bladder, so it's not just so isolated in one area. This bladder in this image is actually a fairly happy bladder. For some of these goats, if this has been going on for a long time, the bladder is very, very friable. And so putting the cruciate pattern in for the stay suture helps, again, it distributes the forces on the bladder a little bit better, so they're less likely to rip. And then you incise the bladder near the dorsal aspect between the stay sutures, which is what this blade is doing here. And you want to have suction ready. This is a full suction tip. And so as soon as the bladder is incised, you put it in the bladder to get any urine out. The next step is then to flush the bladder with saline and remove any stones that are in there. I usually do a rule of 3. So we'll lavage the bladder, I'll stick my hand in there, and if I still palpate stones, we're gonna lavage again. And then if I think all the stones are out, I put my finger in there again. And if I feel any grit or anything that feels like a stone, I'm gonna flush and lavage again. Sometimes you have to even put a scoop of some sort. Actually, little spoons for babies are really good. Because they're small enough and they can fit into the bladders pretty well, just as if they have a lot of stones in the bladder to scoop them out. But you want to make sure you can't feel any stones in the bladder before you close it or do anything there. So I flush, and if I palpate and don't feel any more stones, I flush it and suction it one more time just to be sure. After you've flushed it and determined that there's no more stones in the bladder, you're going to make a second incision into the bladder and also an incision into the body wall that you'll pass the Foley catheter through the body wall and then into the bladder. And then you'll place the balloon into the bladder. So here's the incision in the body wall, and then this is not a Foley catheter. This is called a Pezzer. It's a different tube you can use. I don't like them. I always use a Foley catheter. But this is the incision into the body wall. And then you pass it through. And then this is the secondary incision into the bladder. And you're going to put the Foley through that incision and then into the bladder. I always put the Foley catheter on the opposite side of the body wall that I made the incision into the abdomen. The reason I do that is in case the abdominal incision gets infected, I don't want it to potentially cause an infection where the Foley catheter is. So I put it I always enter on the opposite side of the prepuce and where I made my incision into the abdomen. And again, always fill the balloon with water or with sterile saline prior to placing it into the body to make sure that the balloon actually stays inflated. Then you'll put a purse string suture around that hole to secure the Foley into the bladder. And then the incision that you made between the stay sutures, you close that with 2 inverting layers, typically with a 3-aught absorbable suture, and then remove the stay suture. So this is what it should look like. Again, the catheter going through the body wall into the bladder. And this is another view. So you can see the prepuce would be here. This is the incision into the abdomen, and the Foley catheter is entering the body wall on the opposite side of the incision into the abdomen. Next, once the bladder is closed, you're going to move the bladder and the tube to the side of the body wall where the Foley catheter exits the body wall. You want to make sure that there's no intestine between the bladder and the body wall so that the bladder is flush to the body wall, because you don't want to entrap anything in between them. And then you'll do a finger trap pattern externally to secure the Foley and the bladder in place. And then once it's secure, you inflate the Foley catheter. You can either do it at that time, or I tend to do it after I close the bladder so I can feel it, make sure that the Foley is good before I pull it off to the side. Then lavage the abdomen, especially if the bladder is ruptured, you may need to lavage it several times just to try to clean everything out. If the bladder does rupture, there could be calculi within the abdominal cavity, so you want to try to get that out. And then you close the linea erectus sheath and then skin and subcutaneous tissue. And then secure the Foley to the external body wall. I always try to secure the end of the Foley so it's facing the same direction as the end of the prepuce, so it drips as if the animal was urinating. And then you put a gloved fingertip over the hole and then cut a little hole in it so the urine can drip out, but it's trying to prevent anything from tracking up the Foley catheter to potentially cause an ascending infection. So that's the glove fingertip, and this is another way that the Foley catheter can be secured to the abdomen. Post-op care, analgesics and antimicrobials. Some people say they need to be on antibiotics until the Foley catheter is removed. I have done that. I've also just had them on it for 48 hours and that's been fine. You want to change the glove fingertip every 24 hours, and that glove tip should always be wet because it should constantly be leaking urine. If at any point it is dry, you need to immediately assess your patient because the Foley catheter could be blocked because there could be stones in there, and you may need to flush it or triage in some way to make sure that you can get urine to drip out again. Otherwise, they're going to strain to urinate. They could rupture their bladder or their urethra or something like that. Most patients start urinating out of the prepuce within a few days, but the tube has to be left in place for at least 10 because you're waiting for an adhesion to form between the bladder and the body wall before you remove the tube. And you also want to challenge your patient. So what I usually do if once they start urinating from their prepuce pretty regularly, I clamp off the tube with like a binder clip or something, initially for 2 to 4 hours while someone can watch them to make sure they can actually urinate out of their penis. If they can't do that, you can't remove the tube. Once they're urinating appropriately, the tube, it's really easy to remove. You just undo the finger trap pattern, take the fluid out of the Foley catheter, and then just pull it out. The hole will heal by second intention. But again, that's why you have to wait that 10 days. You want the bladder adhered to the body wall so that hole in the bladder is just coming out of the body wall incision, which will eventually seal over. If you pull the tube too soon and the bladder is not fully adhered to the body wall, then it can fall away when you pull the tube out, and now they're urinating into their abdomen. Prognosis depends on the ruminant and then proper at-home management. I've had animals block a second time and need a second surgery. Things that they can do at home: no grain, because we want to make sure they're ruminating normally. No alfalfa hay, because you don't want anything high in calcium. So feed a really bland grass hay and ensure a proper calcium phosphorus ratio. They can attempt to acidify the urine to help dissolve any residual stones. One thing that's used is ammonium chloride at 300 mg per kg PO, Q24. Usually you'll do this for a week or two and then have them do it for a week at the beginning of every month just to cyclically acidify the urine to potentially dissolve anything. And always make sure they have access to water and that they're drinking appropriately to keep themselves adequately hydrated. Um, the last thing that we'll get to, because I know you have to be done at 11, ruptured urethra. It's usually secondary to urethral obstruction. So this can happen if they aren't treated quickly enough for urolithiasis. And what you'll see is a grossly distended prepuce and caudal abdomen. So you can see the prepuce here is very enlarged and the caudal abdomen is saggy and edematous. And so this can occur again if the urethral obstruction isn't resolved or if the cystotomy tube becomes clogged in the post-op period. So Chester, that 7-week-old goat, his tube got clogged at home and he ruptured his urethra and then we had to euthanize him. The only treatment options once this happens is the perineal urethrostomy or euthanasia, so you can't reconstruct their urethra. And I realized that my chat went away, so I'm not sure if there's any questions. I know you all have to go to class. The next thing I was going to talk about was female urogenital, which is really just going over C-sections. The main thing for the small ruminants is urolithiasis, because that is the #1 emergency I see in small ruminant species. So are there any questions? Because I know you all have to get to another class or something at 11. So any questions about what I discussed so far? The number of Foley catheter recommended for genetic goat. It depends on the size of the goat. So I tend to try to use bigger ones. We usually use somewhere around a 20 to a 24. French catheter, looks like you said 14 to 16. I tend to use the 20s to 24 range. Sometimes it just depends on honestly what I have on hand. Sometimes we don't have the size I want sterile, but that tends to be the size that I use. Any other questions?
I don't think that there is any question for now.
Okay. Like I said, you can give them my email address, and then if there's any questions, students feel free to send me an email later. Thank you for sticking with me. I know this was a lot of information to cover.
Your lecture is great. Thank you very much.
A lot of stuff. So yeah, that is it. I know the students have to move on to other things for the day, so nothing else.
So that is done for today, Dr. Jordan. Yep.
I think so. Yep, I think so.
Yes. Yep. No question. So I would like to say thank you very much for your time today. And what happened?
Someone's not on mute. They don't realize it. Okay.
Okay. Dr. Shaiwat, do you have any question?
Yeah. No, thank you. Good presentation.
Yep.
Right.
Thank you very much, Dr. Jordan. I see you next week. Yep.
See you next week. Yes.
Have a good night.
Bye
Take
bye.
good care. Bye bye.
Bye.